Hi everyone. It's my great pleasure to interview Professor Martin Reincke today. We are at the Portuguese Conference of Endocrinology in Porto, and it's really a pleasure having Professor Reincke with us. As you all know, he's a professor of endocrinology with the main scientific interests in pituitary and adrenal disorders, among many other topics. Today, the topic of his lecture is on Cushing syndrome, and we'll probably start there, Martin. Martin, what are the latest advances in the management of Cushing syndrome?
This is a very good question. Cushing syndrome, I just, of course, have reviewed the literature for the lecture. I figured out that publications on Cushing syndrome have exponentially increased during the recent years. And this is for several good reasons. Number one is, I think, that the diagnosis management is changing currently. Why? So there are new imaging techniques, especially molecular imaging techniques, which are rapidly developing and which give, especially in pituitary Cushing syndrome, where, as we know, MRI is having a 70 to 80% sensitivity to detect the pituitary lesion, molecular imaging can add to that. It is identifying often the source of ACTH. It is also identifying whether the source is close to the cavernous sinus, so it can lead surgical approaches, but also radiation approaches. I've personal experience in our own institution with FET-PET, one of those new imaging techniques. We learned that this has been used by a couple of groups in Europe, mainly in Rotterdam and Basel. We have been in contact with the colleagues. It is a quite interesting journey to see that you can really detect very small lesion with as a bright spot in the pituitary arena. So I think that molecular imaging is one of the hot topics where Cushing's syndrome is really rapidly developing. The other thing is therapy. And in 2012, the first drug for treatment of Cushing syndrome has been approved. This was pasireotide. And since then, we have now four more, mainly adrenostatic drugs, which are approved. There are at least 3 more drugs coming. And what has been the interesting development is that many of the management decisions have changed. For example, medical therapy is nowadays used preoperatively in very severely sick patients. It is used to bridge until surgery can be performed. In some countries, we know that there's a waiting list of 6 to 9 months, and to leave a patient untreated during that time, it's terrible. But mostly it's used for persistent and recurrent disease. In my experience, medical treatment, mainly adrenostatic treatment, really makes a difference. Much of the drama and the chaos which we were observing in patients who are coming in with strong deterioration of their physical abilities can be managed nowadays with single drug therapy or combination drug therapy. In the long run, it is my belief, it has not been shown, that we can really reduce morbidity and mortality in these patients using the drugs which we have nowadays.
And about the challenges on the diagnostic, the laboratorial diagnostic, particularly now in this new era post CRH, as we know that it has been is not supplied anymore, fairing you draw the production. How are you handling, and where do you see future going in this respect?
Very good question, Pedro. I think that we all are experiencing all the time shortages of this and that. So you are mentioning CRH, yes. One has to say that CRH is available from Japan, but at very high costs. I think it's 600 euros in one unit, so very expensive, but you can get it. Other drugs which are currently not available for testing, for example, in Germany, is now synactine, ACTH stimulation tests cannot be performed all of a sudden. So we have to manage with our remaining tools the diagnosis and treatment of our diseases, and that can be quite difficult. So CRH, I would have considered it to be absolutely essential to have CRH. Now we don't have it since 1.5 years, and we still are managing. Okay, we need CRH for subtyping of ACTH-dependent Cushing's, and we can substitute it with desmopressin testing. Desmopressin testing, the number of publications on desmopressin in subtyping ACTH-dependent Cushing is not as high as in CRH. Definitely, it's probably 1/10 in patients' numbers. But I think that it is possible to use it in a similar way as CRH. More challenging, in my view, is the use of desmopressin instead of CRH during petrosal sinus sampling, because there the baseline samples are not enough. We need the stimulation. We are also using desmopressin there. In my experience, it works and it can help. So we have to manage, and I think it's possible to manage. I wouldn't say that the quality of care of the patients have dramatically changed. You always have to keep in mind that, for example, in the US, they never had CRH. They never could use it because the FDA did not allow CRH into the market, and therefore they have always handled without. How have they been doing it? Well, they sent every patient with ACTH-dependent Cushing syndrome just to petrosal sinus sampling. For example, in Harvard, they are doing much more petrosal sinus sampling as we are doing in Central Europe. So my answer is, yes, you can manage. You study the literature, you write your standard operational procedure in your institutions new, and you start and look forward, and I think you will be able to care for the patients.
Thanks, Martin. That's really insightful. I think we can now move more towards the career-related questions, which are tricky, but it's very inspiring to hear well-established clinician scientists as you are. So if you would give us 1 or 2 tips to early career researchers and clinicians how to become a leading clinician and scientist in the field of pituitary and neuroendocrinology.
This is a very good question, as all the others as well. So I would say, first of all, one of the best positions you can become is president of the European Society of Endocrinology. I have always repeating it, saying it. When I was president, I enjoyed it so much. It's a very communicative position, and you meet the best of the best within Europe. So it's a great pleasure. So as a young scientist and clinician scientist, you may not envision that sooner or later you may be able to become the president, but you should always keep it in your eyes. At least you should aim of becoming executive committee member, which is already wonderful. So in my career, when I was around 45 years or close to 50, I became executive committee member of the European Society in 2008, if I remember correctly. And I learned so much at that time. So that already prepared me quite well for then becoming president. But now back to the original question. How do you make a career? Or what is at the basis of a career in endocrinology, whatever you're doing? I believe one thing is very important. You have to find a mentor. Somebody who helps you without his own interest. So a true mentor is a person who's only interested in your interests and not in the own interests. That's hard to find, and it may be not a black and white story, but those who are mainly interested in exploiting you, to put it very badly, these are not the best mentors. They may be very powerful, but sooner or later you will be running into problems. So watch out to mentors who are great leaders, I would say 5-star leaders, who are interested in the subject and in you as a person, but not interested in their own interests. Secondly, you have to address an important topic. So, of course, in terms of career, it's good to have publications, no question. But it's not about, career is not about publication. Publication is a mean to have a career. Important is that you find an important question in clinical or basic medicine which is worthwhile to really spend a lot of time on it. It has to be fascinating. It has to be meaningful to mankind. And it has to be, on the other hand, reasonable. So if you say, I'm interested in visiting the planet Pluto by rocket, that is interesting, but it's out of reach. So you shouldn't do something like that. It should be within reach. I also learned in my own career that it is good to have some flexibility. You heard in the introduction that I'm both interested in pituitary and adrenal. And sometimes if I was stuck in my research work in the adrenal, then I thought, oh, maybe I watch a little bit higher, go to the pituitary and work there a little bit. And when it became there stuck or boring or no funds or so, then I went back to the adrenal. So I was going up and down, and to have more than one topic, this is, I think, the message from my own experiences. To have more than one topic, it is good. If you have only one, there is a risk that you may end in failure, because it becomes, nobody is interested anymore in the topic, because the methods which you have are not fancy enough to answer the questions, because the funding agency decide that this is boring. It sounds crazy, but there is also a topic has to be fancy for the funding agencies. For example, at NIH, I heard that endocrinology as such has become not so interested anymore, whereas oncology and diabetes and metabolism is very interesting. So if you are doing Cushing syndrome, for example, you can move to the oncology field by studying the tumorigenesis of corticotroph adenomas or adrenal adenomas, or you can move to the diabetes field, starting to measure metabolic parameters in the comorbidities of Cushing syndrome. Both ways of keeping your focus on Cushing's, but doing that what the agencies want to see. So mentor, a good topic, and more than one topic, and then the internal motivation is the third thing. What makes, or what in my view, if I look at my mentees, makes the difference between an excellent mentee and an average or very good mentee, this is the internal motivation. So whatever, how good your mentor is, it will not be able that he replaces your internal motivation. That is something you have to find.
Martin, thanks a lot. It's really a lot of good tips and ways for us to really keep looking forward and develop our careers. And so maybe I will go to the last question, how to find a good balance between the professional and the personal life.
That's also a very difficult and challenging question, and I don't have the right answer there. The problem is on the table. If you are 7/24 working, then your private life will suffer. On the other hand, if you work average, so 8 hours a day, 5 times maybe a week or less, then your career will suffer. It's a delicate balance. There is no straight answer to this question. And we also have to reflect on secular trends in our societies. If you speak to older people like me, they often will say, oh, we have been working much harder than the new generation. This is nonsense, to be honest. I have been studying the literature and I've been listening to social sciences, and they are saying the working attitude has not changed so much. Maybe the discussion, the openness of discussion about how you arrange your work-life balance, this is something which may have changed. Or when I'm speaking with my mentees every 3 months, and I have the impression that somebody is overworked, then this is something which I address. Because when you empty your battery, your internal battery, you may not first feel it, but sooner or later it will affect your professional life. And it's much better to be more careful with yourself in the beginning and to realize that you may have used more of your energy than you thought you have. So it's something which I always address in my meetings with the mentees. And personally, I try also to ask myself, am I doing too much? Am I hurting or offending myself or my social life, my friends and my family? So it's always good in this way to ask the question. Ask yourself and ask your family and your partners. Do you think that I'm working enough or too much? Then that will help to find the right balance.
Thanks very much. It was really useful, really inspiring as well, and certainly, hopefully, will help lots of young, early career endocrinologists. I hope you have a good time in Porto, and see you soon. Thank you very much, Martin.
Yeah, thank you. Porto is a great place, so who has not been here should go. It's wonderful, wonderful city. As far as I've been here now 24 hours. I've been some time before, but what I've been seeing is great. So a great place to be, as it is said. Thank you, Pedro.
Thank you.